Hello and welcome to today's session. Today we're looking at skin disorders, and skin disorders emanate from the integumentary system. And we have various conditions here, like the vitiligo, vitiligo condition, as a pigmentation skin disorder, pediculosis infestation. We also have the ringworms, we have the melanoma, the malignant skin cancer, we have the scabies, we have the impetigo. We have different skin disorders that are classified differently, and they could be having papules. These are small solid elevations on the skin. They are normally less than 1 centimeters, and they are associated with skin disorders such as acne vulgaris, psoriasis, and lichen planus. The vesicles, these are small fluid filled blisters on the skin. These are less than zero point 0.5 centimeters. They are mostly associated with herpes simplex, chickenpox, poison ivy, oak, and dermatitis. We have pustules. These are small pus fluid-filled lesions. Remember, vesicles are fluid-filled. These are pus-filled. They are pustules. They are similar to vesicles in that they are less than zero point 0.5 centimeters, and they do occur in a person with acne vulgaris, impetigo, and folliculitis. We have macules, and these are flat discolored spots on the skin, less than 1 centimeters, and this is associated with flakes, flat moles, and petechiae. We have nodules. These are solid, elevated masses in the skin, larger and deeper, and these are associated with lymphomas, dermatofibromas, and cystic acne. We have the cysts. These are enclosed sac-like structures filled with liquid or semi-solid material, deeper and larger, associated with the epidermoid cysts, the pilonidal cysts, sebaceous cysts. The plaques, these are large, raised, flat-topped lesions. These are greater than 1 centimeters, okay, and associated with psoriasis, lichen planus, eczema in some cases. The wheals or hives, these are red, raised, and itchy welts on the skin, and these are associated with urticaria and allergic reactions. The bullae are large filled blisters on the skin greater than zero point 0.5 centimeters, associated with bullous pemphigoid and pemphigus vulgaris contact dermatitis in severe cases. Lastly, we have erosions. These are superficial loss of skin, often following rupture of the vesicles or a pustule. So it normally follows rupture of vesicles of pustules, e.g. after herpes simplex outbreaks. So guys, skin disorders are generally classified based on different criteria. We could have clinical presentation and symptoms. So skin disorders are classified based on the visible symptoms and clinical presentation. For example, we could have disorders characterized by redness. Okay, and what did we say redness is? Whatever is associated with, guys? Redness? Yes. Yeah, so mostly the hives, yeah, they are the red raised. Okay, so we could have such disorders that are redness, itching, inflammation, and might be classified as inflammatory dermatitis, the hives, or disorders presenting with blisters, scales, or papules. Okay, and could also be categorized accordingly. We could also classify skin disorders based on the etiology. Etiology is the cause, and for instance, disorders caused by bacteria like the impetigo, or disorders caused by the viruses, the herpes simplex virus, the fungi, the parasites, and these are classified as infectious dermatosis. Whereas we also have autoimmune disorders, genetic mutation, allergies, or environmental factors can also cause skin cancer conditions. Number third criteria is anatomical location. So skin disorders are classified based on where they are found on the body. Some disorders are localized to specific areas such as the face, the hands, the feet, the mucous membrane, while others affect larger areas of the body and even the entire body surface. Histological characteristics. Skin disorders are classified based on the histology, the microscopic characteristics observed under microscope. So skin biopsies can reveal specific patterns of inflammation and cell types and structural changes that are characteristics of certain skin conditions. Guys, we can look at the link above and you can look at the types of biopsies. All right. Correct. So infectious dermatologic disorders include the bacterial infections like impetigo, cellulitis, and erysipelas. Viral infection include the herpes simplex, the herpes zoster, the shingles, and warts. Fungal infection will include the ringworms, the tinnitus, the candidiasis, and the dermatophytosis. Parasitic infection will include infestations like the scabies, the lice infestations, and the bedbug mites. On the other hand, the inflammatory dermatological disorders could include eczema, this is dermatitis. Examples include atopic dermatitis, contact, and seborrheic dermatitis. We could also have psoriasis, which is a chronic autoimmune condition characterized by red, itchy, and scaly plaques. Or acne, this is a common inflammatory disorders of the sebaceous gland and the hair follicles and majorly affects the adolescents. Lupus erythematosus is an autoimmune disorder affecting the skin and other vital organs like the kidney. The pemphigus is a rare autoimmune blistering disorder, and vasculitis is the inflammation of blood vessels in the skin. Allergic dermatologic disorders could include like the hives, urticaria, and angioedema, allergic contact dermatitis, skin reaction due to contact with allergens. We also have pigmentary disorders like vitiligo, loss of skin color due to the destructions of melanocytes. We have melasma. These hyperpigmentations often triggered by hormonal changes. It sometimes occurs in pregnant or expectant mothers. Post-inflammatory hyperpigmentation, this is the darkening of the skin following an injury or inflammation. Then you have neoplastic dermatological disorders like skin cancer, including the basal cell carcinoma, squamous cell carcinoma, and melanoma. Benign tumors such as the seborrheic keratosis and dermatofibroma. Autoimmune and connective disorders, you have the scleroderma. Okay, these are chronic hardening and tightening of the skin and connective tissue. The dermatomyositis, this is inflammatory disorder affecting skin and muscles, while the panniculitis, this is inflammation of sebaceous or the subcutaneous fatty layer. So genetic and congenital dermatologic disorders. We have the epimayolysis bulosoma. These are genetic disorder causing blistering and fragility of the skin. Whereas the ichthyosis is the group of genetic disorders characterized by dry, scaly skin. Albinism is characterized by absence of melanin pigment in the skin, hair, and the eyes, while the vascular dermatologic disorders include the hemangiomas and the telangiectasia. So one of the commonest disorder is the scabies. It's also referred to as the 7-year itch, and it is transmissible skin infection with the Sarcoptes scabiei hominis. It's also referred to as the itch mite and is characterized by the barrows and severe pruritus and the excoriations. So severe form is what is referred to as the crusted scabies and is commonly referred to as the Norwegian scabies, which contains hundreds to thousands of mites in the skin, as opposed to the common one, which is normally presents with 15 to 20 mites with that. Common site of infestation include the spaces between the finger webs and in the folds, the crevices and the spaces of the groin, genitalia, breast, buttocks, and the axillary folds. So Subestis cepae, the itch mite is normally transmitted through the skin-to-skin contact and sexual encounters or through infected materials such as the clothing and bedding. So the mites will burrow into the skin on contact, progressing 2 to 3 millimeters per day. Female, they normally live 4 to 6 weeks and they lay about 40 to 50 eggs, which hatch in 3 to 4 days. So pruritus will occur only after sensitization to the mite develops. So with the initial infestation, sensitization requires several weeks, but with the reinfestation, sensitization will develop within 24 hours. So dead mites, the eggs and the larvae and their excrement will trigger an inflammatory eruption of the skin in the infested areas. So we could have the Sarcoptes scapae, and you can be able to appreciate my diagram on my left. So causes, we have the direct skin-to-skin contact, okay, and the sexual contact. And you find that sexual contact is normally the primary mode of transmission in young adults. Risk factors include overcrowded living conditions, poor hygiene, daycare institution, and immunocompression. So with the immunosuppression. The complication you have excoriations, the secondary bacterial infestation, abscess formation, and septicemia, although it's rare. So scabies is common in young adults and older adults and in patients with debilitating conditions. It is estimated worldwide that we have an annual occurrence of about 300 million cases. It can be endemic in some areas, but outbreaks normally occur most commonly in the fall and winter in the developed countries, but year round in developing countries. So when you are assessing this patient, you're supposed to look at the history where you try to elicit the predisposing risk factors. Sometimes you may find the patients are asymptomatic for up to 6 weeks, but you could report intense pruritus that is more severe at night and becomes more increasingly more severe over 2 to 3 weeks. Rash that forms in a line could also be one of the striking features. When you do the physical assessment, you find that on physical findings will include characteristics gray-brown thread-like burrows that is 0.5 to 1 centimeters long with a tiny papule or vesicle at one end. Could also have erythematous papules and vesicles and papules, vesicles and crusting abscess formation and cellulitis with secondary infection. Lab techs, you could do the wound culture and sensitivity to demonstrate secondary bacterial infection. Also, the immunoglobulin E titers may be elevated. So we have mineral oil barrow scraping reveals mites, needs, or eggs and feces or the scribler. The punch biopsy may help confirm the diagnosis. Light microscopy of the skin scraping will identify the larvae and the mites. Clinical findings also help confirm the diagnosis. Resolution of the infestation with therapeutic trial of penicillin confirms the diagnosis. An adhesive tape test reveals the mites and the eggs. General treatment, you find that bathing with soap and water and proper skin care, environmental and clothing decontamination, and treatment of patients' close contacts. In terms of diet, there is no restriction. Activity, it's limited interaction with others until it's treated. But you need to remember that you need to avoid topical steroid during acute infestation because they may potentiate the infection. Remember, one of the risk factor is immunosuppression, and that is what corticosteroids are good at. But once the mite are eradicated, it is now safe to use medium or high potency topical steroids to control the itching. So we could have the scabicides like the permethrin or the ivermectin or the troctameton lotion that has 10% or 6 to 10% sulfur solution. Systemic antibiotics for secondary infection could also have the antipruritic like the diphenhydramine hydrochloride, cetirizine hydrochloride, or the loratadine to control itching. We could also have topical antibiotics such as mupirocin for secondary infection, and we could also have the ketolytic agent to aid absorption of these topical treatments, including permethrin, especially in cases of crusted scabies. So as a nurse, you need to trim the patient's fingernails so as to minimize scratching that will predispose the patient to secondary infection. You need to apply topical medication as directed, maintain contact precautions until treatment is completed. Guys, to get to know how to carry yourself during contact precautions, you can click on the link so that you're able to get it. Practice meticulous hand hygiene for at least 20 seconds. Decontaminate linen, towels, clothing, and personal articles. After discharge, you need to disinfect the patient's room and any equipment that you come in contact with the patient. Encourage the patients and the family members to verbalize their feelings, then observe wound and skin precautions for 24 hours after treatment with the scabicide. Help remove crusts using warm water socks, and then prepare all households and close personnel contacts for treatment, even if they show no signs. The second commonest condition is pediculosis, and this is the infestation of the human parasitic lice, which normally feed exclusively on the human blood and lays eggs on on the body hairs, clothing fibers, and after hatching, they must feed within 24 hours or die. So preschool and elementary school age children are the primary hosts for Pedicularis capitis and Pedicularis corporis. Types of pediculosis, you have the pediculosis capitis. This is the head lice and is confined to the scalp and is occasionally eyebrows, eyelashes, and the beards. The pediculasis corporis, this is the body lice, and this is found next to the skin in the clothing, it seems, and then it moves to the host only to feed on the blood. Pedicularis pubis, this is for the pubic or the crab lice, is found primarily in the pubic hairs, may extend to the eyebrows, lashes, and axillary or the body hair. So we could have the body lice, could have the pubic lice, and then have we have the head lice, then you have the body, this is the body lice, and then you have this is the pubic lice. So on the pathophysiology, you find that transmission occurs from person to person via close physical contact or through fomites. Okay, these are just elements where they can that can be used to transmit or spread diseases, and this could include the combs, clothings, hats, linen. Okay. Remember, fomites are inanimate objects. Okay. Fine. So we have the lice, they crawl and they attach superficially to the epidermis and the hair, or infest the clothing, laying eggs on the fibers in the fabric seams. So one female louse deposits approximately 60 to 150 nits of the hair shafts or the fowls into their body to feed. So nits will survive by ingesting blood from the human host. So allows bites injects a toxin into the skin. So mild irritation and pruritic spot results. But you find like repeated bites now will cause sensitization to the toxins, leading to more serious inflammation. In some severe cases, sensitization causes wheals or rash on the trunk. Scratching can result into secondary infection. So Pedicloris capitis is the Pedicloris humans. So it's spread through shared clothing, hats, combs, hairbrushes, hair brushes, and the headgear, crabs, and linen. Whereas the Pedicloris corporis for the body spreads through shared clothing and bedding, especially with environmental crowding, prolonged wearing of same cloth, poor personal hygiene, or sharing of tiles used by infested individuals. Cats, dogs, and other house pets are not responsible for the transmission. Okay? Pediculoris pubis, this is spread through sexual intercourse or contact with clothing, bedding, or towels harboring the lice. Risk factors could include poor hygiene, overcrowded living conditions, or congregate settings, immunosuppressions. Find that the exact incidence is unknown, but it's estimated that around 12 million people ages 3 to 11 in US are affected annually. Pediculosis capitis is the most common in urban areas across all socioeconomic groups, while pedicularis corporis is mostly common in homeless population. So pediculosis capitis is generally more common in females than in males. Pediculosis capitis infestation commonly occurs during late summer and autumn. Pedicularis pubis infestation are more common in cooler months. Complication will include the skin excoriations, secondary bacterial infection, hyperpigmentation or residual scarring, and reinfestation. When carrying out assessment, you need to elicit exposure to a causative agent if the patient is experiencing headache, fever, malaise, pruritus, or cutaneous changes. On physical examination, you want to see if there is visible lice, especially for the head, or skin excoriations on the scalp and the neck, lutless hair in some areas, occipital and cervical lymphadenopathy, oval gray-white nits visible on the white shaft. For the corporis, we could be looking for the red papules on macules, especially on the shoulders, trunk, and buttocks, excoriations from scratching nits on the clothing seams. We could also have the pedicularis pubis. We look for the visible brownish gray lice, erythematous papules, small macules on the thighs, buttocks, or lower abdomen, coarse gray, white gray nits attached to the pubic hairs, or inguinal and axillary lymphadenopathy. So for the diagnostic test, we could do direct inspections with the hand lens using shows visible lice or nits. Could also do wood light examination, which shows yellow-green fluorescence of live nits. Remember, dead nits don't fluorescence, okay? In terms of treatment, you could use the wet combing after hair is soaked for 15 minutes in equal parts of water and white vinegar. Do hand washings with coconut or olive oil shampoo, plastic bagging for 2 weeks of items that can't be laundered. We could also do vacuuming of the environment, bathing with soap and water, petroleum jelly applied to the eyebrows or eyelashes, washing of infested clothing, linen, bedding with hot water of over 54 degrees Celsius, or drying in a dryer or hot setting. Dry cleaning as an alternative for items that cannot be laundered. So items must have been stored in a double sealed plastic bags for 2 weeks and transported that way to a certified dry cleaner. In terms of treatment, starting with the pediculosis capitis, we could have topical pediculicides such as the pyrethroids, oral ivermectin if topical treatment fails. For the body pediculosis corporis, you could use topical permethrin or topical corticosteroid cream applied to pruritic and irritated areas. Pedicularis pubis, we could use pyrethrin 1% or permethrin shampoo, pyrethrins, and melatonin or lotion or oral ivermectin as an alternative treatment. So for a nurse, what are you supposed to do? You're supposed to assist the patient in the use of prescribed treatment regimens. You need to instruct the patient to leave the shampoo on for 10 minutes, then rise. Apply the lotion and leave it for several hours. Apply the spinosad to dry air for 10 minutes, then rinse with warm water. Implement the standard precautions and use the PPEs when administering the lysine treatment, and implement contact precaution for the first 24 hours after treatment. You need to encourage the patient to express feelings about infestation and provide emotional support. and encourage the treatment of family members and other close contacts. All right. Another common condition is the melanoma. This is a malignant skin cancer. So, neoplasm normally arise from this neoplasm will arise from the melanocytes. These are found predominantly in the skin, but can be found in the gastrointestinal tract, genital tract, mucosa, and also the eyes. Potentially is the most lethal of the skin cancers, and it's rare in persons with darker skin. Common site of those exposed are excessive sunlight on at the head and neck in males, legs in females, and back in males and females. Other sites include the eyes, the mucosa, gastrointestinal tract, and genitourinary tract. We have five subtypes. We have superficial spreading melanoma, which is approximately 60 to 70% of malignant melanomas, making it the most common type and usually develops between ages 40 and 50 and usually occurs on the legs, arms, and upper back. Nodular melanoma is the second one, and it's approximately 15 to 35% of malignant melanomas, and it grows vertically, invades the dermis, and metastasizes early, usually develops between ages 40 to 50, and usually occurs on sun-exposed areas. The acral lentiginous melanoma is the third one, and it's a rare form of malignant melanoma that is extremely aggressive, occurs in palms and soles and under the tongue. The lentigo maligna melanoma is the fourth one. It's a rare form of the malignant melanoma and is the most benign, slowly growing and least aggressive of the five types. Most common occurs on the skin heavily exposed to the sun, arises from the lentigo maligna on the exposed skin surface, and usually occurs between ages 60 to 70. Lastly, we have mucosal lentiginous melanoma. It's approximately 3% and develops from the mucosal epithelium lining the respiratory, GI, genitourinary tract, possibly more aggressive, but often diagnosed at a later stage. So we could have the superficial spreading melanoma, nodular melanoma, acral lentiginous melanoma, and lentigo maligna melanoma. Those are some of the examples. So melanomas will arise because of malignant degeneration of melanocytes located either along the basal layer of the epidermis or the benign melanocyte nevus. Up to 70% of malignant melanomas arise from pre-existing nevus. Initially, the cells grow radially through the epidermis. Eventually, they spread vertically through the dermis, which allow for metastasis. So malignant melanomas spread through the lymphatic and the vascular systems and metastasize to the regional lymph nodes, skin, liver, lungs, and central nervous system. Malignant melanomas follows up unpredictable course, recurrence, and metastasis, and may not appear until more than 5 years after resection of the primary lesions. Skin causes could be skin damage associated with the exposure to ultraviolet rays from the sun. Possibly a combination of factors including environmental and genetic could be the cause. Risk factors include excessive exposure to sunlight or tanning beds, especially if blistering sunburn occurred. Skin type could have blonde or red hair, um, fair skin, and blue eyes. These are prone to sunburn. Could it be Celtic or the Scandinavian ancestry? All these are the risk factors. Hormonal factors, especially in pregnancy, um, family history of melanoma or the xeroderma pigmentosum, pre-existing pigmented mole or nevus, being white. Yeah, in fact, being white, if you find that someone is 20 times more common, 20 times more likely to get or develop melanoma for the white. Okay, if white is 20 times likely to develop. Someone with an age is also a factor. We have some age, when you have age over 50, the risk increases. We also have high follicle density or density tendency to develop follicles after sun exposure. Presence of actin lentigens, also known as liver spots, sunspots, or age spots, Parkinson's disease, and immunosuppressions. All these are the risk factors for developing melanoma. Malignant melanoma accounts for approximately 1% of skin cancers, causing more deaths each year than non-melanoma skin cancers. It's slightly more common in males than females and is the fifth most common malignancy in males and the sixth common in females. Peak incidence will occur between ages 50 and 70 with an average of 65, but incidence in younger age groups is increasing. So most studies are still being done just to find out the reason why. It's more common malignancy in females between ages 25 and 29, and incidence is 20 times higher in whites. I think that one we had indicated. And complication will include metastasis to the lungs, liver, or brain, causing all the signs and symptoms associated with those organs. Infection, difficulty in swallowing if the throat is involved, and recurrence. In terms of history, you have to see if there is a sore that doesn't heal, persistent lump, or swelling or changes in pre-existing skin markings such as moles, birthmarks, scars, freckles, or warts. Pre-existing skin lesions or nevus that enlarges, changes color, becomes inflamed or sore, itches, ulcerates, bleeds, changes texture, and shows signs of surrounding pigment regression. Also, another risk factor that needs to be listed is family history of multiple nevus syndrome, skin cancer, or malignant melanoma. Then you have previous history of melanoma and the skin exposure. So physical findings include atypical lesions that are asymmetrical with the broader irregularity, dark black, blue, or varied color greater than 6 millimeters in diameter and elevated skin above the skin surface. Lesions on the ankles, back, or inside of the knees. Uniformly discolored nodule on the knee or the ankle. Small elevated tumor nodules that may ulcerate and bleed. Palpable polypoid nodules that resemble the surface of the blackberry. Pigmented lesions on the palms and soles or under the nails. Long-standing lesions that have ulcerated or flat nodules with smaller nodules are scattered over the surface could be some of the findings that you could be able to get. Remember, when examining a patient's skin for lesion, you must differentiate what might be a melanoma from a benign nevus using the ABCDE system for evaluating the lesions. So A, you find that the melanoma is asymmetrical, whereas the benign nevi is symmetrical. B, you find that the melanoma has irregular borders, whereas the benign nevi has regular borders. C, you find that the melanoma usually is dark or black with variations in color, whereas the benign nevi is light tan or brown with uniform color. D is the melanoma may have a diameter greater than 6 millimeters, whereas the benign nevi has a diameter of less than 6 millimeters. Lastly, in terms of evolution, find that melanoma over time changes in size, shape, color, surface, or symptoms do occur, such as itching or tenderness, whereas for benign nevi, there are no changes there. In terms of laboratory, that's the diagnostic test results. Starting with laboratory, we could have the CBC, which shows differential anemia, or we could have the ESR, erythrocyte sedimentation rate, which shows they are slightly elevated. Platelet count is abnormal if the metastasis has occurred, and the lactate dehydrogenase test results shows are elevated with advanced metastasis. In terms of imaging, chest radiography will assist in disease staging, and computed tomography scanning, magnetic resonance, and positron will help in staging. All right. So the results of this excisional biopsy or full depth bunch biopsy with histologic examination can show tumor thickness and disease staging. Imaging technologies such as dermoscopy and reflectance confocal microscopy may improve the early recognition of the melanoma. So if for the dermoscopy, it's also referred to as the epiluminescence microscopy. It's an incidence light microscopy and the skin surface microscopy. Dermoscopy is a non-invasive examination of the pigmented lesions with the use of optical system. So types of optical system could include dermoscopy, stereomicroscopy, and video dermoscopy. So each system magnifies the lesion for evaluation and requires specific training. Whereas the reflectance confocal microscopy uses a low power laser that emits near infrared light that reflects off structures in the epidermis. So we have melanin granules have high reflective index. So areas of higher melanin concentration appear as dark areas on the confocal image. So the remittance confocal microscopy may help in recognition of a melanotic or hypermelanotic melanomas and in mapping lentigo-maligna margins before surgical excisions. It also allows for rapid imaging of multiple lesions and can be used for digital monitoring of lesions over time. It uses RM requires formal training as opposed to the dermoscopy. In terms of treatment, we could do the close-term follow-up care to determine metastasis and recurrence. We avoid sun exposures, do venous thromboembolism prophylaxis when the patient is hospitalized. Activity could be as tolerated, and the diet will be needs a well-balanced diet. We can use the antineoplastics such as the damacarbazine, cisplatin, carboplatin, paclitaxel. Could also have immunotherapy such as the yes, we have the pedrolubizumab, or targeted therapy such as the vumefimid. Okay, analgesics. Could also do surgery section to remove the tumor and regional lymphadenectomy. So we also need to encourage verbalization of feelings, prepare the patient and family for surgical incision as indicated, provide adequate surgical site care, inspect the area for signs and symptoms. Okay, so you also need to screen and assess the patient's pain, treat the patient's pain. You also monitor closely if the patient is at high risk for adverse outcomes related to opioid use, reassess and respond patient's pain, give prescribed medications. If the patient is receiving cisplatin, ensure adequate hydration before and after 24 hours treatment to reduce the risk of nephrotoxicity. Provide a high protein and high calorie diet. Apply anti-embolism stockings or sequential compression stockings to prevent venous thromboembolism. Also monitor weight for changes and obtain specifics for the laboratory testing. Okay, evaluate for hypertension if the patient is receiving interleukin 2. Okay, so guys, you could have also vitiligo. These are chronic. Okay, guys, this is a chronic, long-lasting autoimmune disorder that causes patches of the skin to lose pigmentation or color. It normally happens when the melanocytes these are attacked and destroyed and turning into a milk white color. Whereas albinism is an inherited condition that can lead to someone having very light skin, hair, and eyes. It happens when they have less melanin and are usually in their body. Okay guys, so these are the conditions. You could also follow up the link just to get more information about the burns, the pressure ulcers, and so on and so forth. Thank you so much, and you can be able to attempt the free quiz in the description section.